right, well, thank you, and good afternoon, everyone. Welcome to ASCP's Best Practices in Advanced NSCLC Project Echo video conference series. My name is Kelly Beimer. I'm ASCP's Director of Learning Innovations, and I'll be the facilitator for today's session. Throughout the presentation, feel free to turn your video on, but please keep your microphones on mute unless you've been called upon to speak in order to minimize disruptions. A copy of the disclosures can be seen on the screen. In addition, today's session is funded by independent educational grants from Janssen Biotech, Inc., administered by Janssen Scientific Affairs, LLC, and by Pfizer, Inc. Please note that this video conference is being recorded, and by participating in this recorded video conference, you're agreeing that ASCP may use the recording of your image and statements on ASCP's website and YouTube channel. Now, before we get started, we definitely want to get to know each of you and tell you a little bit about how these Project Echo video conferences work. So if you could each take a moment to type in your name, your title, and your institution into the chat. Great, and then we also have a few polling questions that we'd like to ask. So we'll get those displayed on the screen, and if you could please take a moment to answer those questions, we would greatly appreciate it. And then while you're all answering the questions, I'll tell you a little bit about the Project Echo format that we're using today. We're incredibly excited to have Dr. Paul van der Laan here with us today to share his expertise on optimizing test ordering in patients with advanced NSCLC. Then following his presentation, we'll have Dr. Nirupama Singh and Kimberly Bennett share the challenges that they've faced in their institutions, along with any lessons that they've learned along the way. As a reminder, these sessions are designed to be interactive, so we'll be opening the floor up for discussion at several points throughout the presentation to allow all of you the opportunity to ask questions, provide comments, share your experiences, and learn from each other, just in the hopes that you'll find useful information from these discussions to help you overcome any challenges that you might be facing in your institutions. Okay, and we're going to go ahead and close the polling questions now, so thank you all for your input. Okay, and just a few final reminders before we get started. Please make sure that you keep yourselves muted unless you've been called upon to speak during the discussions. Please don't share any protected health information or personally identifiable information about patients. And finally, CME and CMLE credit are available for this event. Instructions for claiming credit will be shared at the end of this presentation. It will be available on our lung cancer website, and it will also be sent to the email addresses that you provided at the time of the registration. So now it is my pleasure to welcome Dr. Paul van der Laan to today's Project Echo video conference. Dr. van der Laan is the Director of Cytopathology and Director of Thoracic Pathology at Beth Israel Deaconess Medical Center, as well as an Associate Professor of Pathology at Harvard Medical School. And he'll be sharing best practices for optimizing test ordering for patients with advanced NSCLC. Dr. van der Laan, the floor is yours if you'd like to share your screen.
Thank you to the ASCP for inviting me to talk to you briefly today about this topic. And these are my disclosures, nothing to do with what I'll be talking about this afternoon. And a happy lab week to everyone who's watching this live. It's great to have a week to kind of celebrate everything that the laboratory medicine and everything we do in pathology. And so this series, is really quite unique and quite interesting. And if we think about a lot of the educational and didactic sessions we have about lung cancer, oftentimes it's focused on the diagnosis, the actual testing, maybe even some of how to manage the specimens. But this is really the first time that I think that I've been involved in, or somebody has wanted us to speak about how do we actually deal with the nuts and bolts of ordering the testing, something that all of us in pathology are dealing with on a regular basis, and something that has a huge impact on patient care, but something that, really isn't thought about that much. So hopefully, through the course of this hour, we'll have a good opportunity to garner some best practices and to think about this whole process of ordering tests in non-small cell lung cancer. And so as everyone in the audience, I'm sure, is very familiar with, lung cancer unfortunately remains the leading cause of cancer-related death in the United States and in the Western world. And despite a number of the advances that have been made on diagnosis and treatment, it still is a leading cause of death. And unfortunately, also the majority of lung cancer cases are still seen at presentation at advanced stage disease, where these patients really are not surgical candidates. And so as such, the only specimens that we tend to have on these patients in the pathology and cytopathology laboratories are those cytology and small biopsy specimens. And of course, if we think about what needs to be done with those precious small little biopsies, it has been increasing over the years. And so not only must we establish a diagnosis of malignancy on these small biopsy specimens, but we do have to provide some level of tumor classification using a focus panel of immunohistochemical stains, all while maintaining adequate materials for this growing number of ancillary and molecular tests that are absolutely essential to direct the care of these patients with advanced stage lung cancer. And if we look in April of 2021, the list of targetable mutations has grown rapidly over the last couple of years. And so, at this current point in time, we now have 7 distinct biomarkers that have FDA-approved therapies, and these include EGFR, ELK, ROS1, the BRAF V600E mutations, NTRK rearrangements, MET-exon 14, and RET rearrangements. And so those 7 biomarkers plus PD-L1 immunohistochemistry really is the minimal amount of biomarker testing that we need to do given the FDA approvals. And of course, as time rolls on, we have a number of emerging and evolving therapeutic targets, including ERBB2 mutations, MET amplification, and hopefully the KRAS G12C mutations that will soon be targetable with promising phase 2, phase 3 clinical trials and FDA approvals. So as you can see that there is this huge need for accurate biomarker testing and comprehensive biomarker testing in order for the oncologist to identify those targets that can be targetable. So that really begs the question, with this growing number of tests and biomarkers that need to be assayed, how do we get this testing done? And for most pathology practices, most institutions, with non-small cell lung cancer, the first branch point or the decision point that needs to be made is whether we do this testing in-house or we send out to a reference laboratory. And these metrics and this decision has become a little bit more difficult with the growing number of biomarker targets, making it more and more difficult to rely on single gene assays. And rather, as many professional societies have supported and have endorsed, really the need for broad-based, panel-based testing, usually by next-generation sequencing, is needed. So the data on next-gen sequencing in non-small cell lung cancer specimens is a little difficult to get accurate data, but the best that I've been able to find that in the United States, approximately 35% of NGS testing for lung cancer is done in-house in in-house molecular laboratories, mainly at large academic medical centers, whereas 65% of all testing is done at send-out reference laboratories. And of course, the decision of where this testing should be made is somewhat complex, right? Dealing with, we have to consider the facilities and the personnel and the expertise locally to be able to do the testing. What type of testing volume would be generated and can your in-house laboratory handle, for example? What is the turnaround time that your laboratory could achieve or a send-out laboratory could achieve? Is that sufficient, or is that acceptable to your clinical colleagues? Cost and billing certainly is an important metric, and also the type of specimen that the testing would be performed on. In general, most send-out reference laboratories do require FFPE specimens, and so if you're generating a lot of direct smears or cytology specimens, that might be a little bit more difficult to rely on a reference lab for this broad-based NGS testing. And really, again, over the last couple of years, the tides have been shifting, and guideline recommendations, both by the CAP as well as the NCCN, really have recommended broad panel-based testing, in order to cover in 2021 those 7 biomarkers plus PD-L1 immunohistochemistry as the minimum number of testing targets that need to be covered. Of course, there are the emerging targets that can be very helpful for identifying patients and enrolling them in clinical trials, or as the data matures in phase 3 clinical trials and FDA approvals, hopefully new therapeutic options will become available. In addition, our oncologists really appreciate the additional and information that is garnered from large NGS panels, including tumor mutation burden, MSI status, the co-mutational profile that's seen in lung cancer that can again help predict a responsiveness to immunotherapy or TKIs. Of course, with the next-gen sequencing large panels, there is a cost potential limitation, though. Now that we're dealing with an increasing number of mandatory biomarkers that need to be tested for, really the scales have tipped in NGS testing favor over single gene assays. As alluded to earlier, the availability of in-house it can be an issue, and then turnaround time. And turnaround time is something that is so important and something that our oncology colleagues hone in on appropriately so. And really, so that begs the question of how can we in pathology, what can we do to minimize that testing turnaround time? And so if we look at the 2013 and then the revised 2018 CAP guidelines for testing, biomarker testing in non-small cell lung cancer, the benchmark was put out there saying that really we should be aiming for, a target of 10 working days or 2 weeks for the testing turnaround time by the testing laboratory, be that an in-house lab or on a send-out vendor. And if you are dealing with a send-out vendor, we should have a maximum of 3 working days to get that paraffin block to them from when receiving the test in the molecular, in the pathology laboratory. Or if we're sending our block to an in-house molecular lab, we should really be able to do that within 24 hours. And so the point there is that the turnaround time that the oncologist or the clinicians see or feel is actually an amalgamation of the pre-analytic, the analytic, and the post-analytic testing phases. We oftentimes focus so much on the analytic phase, or how long it actually takes the molecular laboratory to perform those tests. Although the pre-testing interval and the post-testing interval are equally important, and honestly for pathology is something that we can control, we are under more control under, and things that we can actually hopefully hone down and maximize the efficiency of those pre-analytic and post-analytic testing phases. This is something that we looked at our institution a number of years ago now, back in the era of more reliance on single gene assays. And we were able to find that, yes, approximately 80% of our non-small cell lung cancer specimens that were sent out to a reference laboratory could achieve that total less than 10 working day turnaround time. But we did break down in a quality improvement project that our quality improvement specialists and in truth, many man hours of resident and trainee quality improvement project looking into this, we were able to look at the different testing phases and found the variability and actually bottlenecks in different pre-analytic phases. And in doing so, we were able to streamline that process. And so I think this is an example of those quality improvement projects that really can bear fruits and pay dividends if you can identify where those bottlenecks might be. So in addition to just purely the turnaround time testing total, the testing time total, you can think about this process as being incredibly complex. And it is something that you can break down into the ordering, the specimen collection, transport, accessioning, and processing phases. And each one of these have a number of potential steps that can be a patient safety risk issue as well. And so you really need to identify the things that you can control and hone in on any problems that might arise in any one of these specific areas. And in addition to the actual testing and workflow complexity, you can see that there's also numerous stakeholders who are involved in this process at every phase along the way. And so really, it's something that you can't do just by yourself to optimize the system. You really need to identify all the stakeholders, the clinicians, the proceduralists, the couriers, the lab personnel, et cetera, to identify again, those bottlenecks. Where are those pressure points where things can be optimized in order to develop systems for an efficient and predictable testing workflow. And I'm sure this is something that we'll talk more about in the other phases of the presentation today. What are the things that work and what are the problems that have been identified? Locally here at BIDMC, we really worked to establish a uniform workflow so that all specimens were treated the same way and had defined checkpoints along the way to ensure that they are being processed and handled accordingly before being sent out. We have a dedicated send-out coordinator, which is a tremendous asset to have. Somebody in charge of coordinating the send-outs, making sure if there are any problems that people on the clinical side or people in pathology are contacted quickly in order to resolve those problems and get the specimens to the reference laboratory as quickly and efficiently as possible. Then, of course, it's wonderful in an ideal world if there are LIS solutions where ordering can be made electronic or automatic, and maybe even a tracking system along the way. Those are wonderful things where we can use technology to help increase the efficiency and accuracy of this ordering process. So now, another important question, or something to think about, is who initiates the testing that needs to be done. And this is a little bit of a busy slide, but it's my best shot at trying to distill down the two options. Either we have a pathologist-initiated reflex testing paradigm, or we can rely on an oncologist-initiated testing ordering system. Both have their pros and cons, but to go through them very briefly, I think that for the pathologist reflex testing paradigm, some of the benefits are that it, number one, certainly will increase testing rates and will help minimize any specimens that might fall through the cracks. Fortunately, that increased testing rate is at the risk of over-testing or duplicate testing that can have implications for reimbursement and increasing total overall cost. Certainly, a reflex testing paradigm in the literature and in practice has been shown to decrease the overall turnaround time for those testing results, because as soon as the pathologist sees that specimen, chooses that best specimen, and initiates the testing, that clock is started, and it decreases the effective time to treatment for these patients with lung cancer. And finally, nobody knows better than the pathologist or the cytopathologist what is the best specimen to send for testing. And of course, this is very important for those bronchoscopic procedures where multiple specimens might be generated during one procedure, including a transbronchial biopsy for histopathology, transbronchial needle aspirations, EBUS TBNAs of lymph nodes that go to cytology. And so by coordinating in pathology and cytopathology to identify which is the best specimen to test, you really maximize the chances for testing success and minimize tissue insufficient quality. We know how that specimen has been handled as well. Hopefully, if a specimen needed to be decaled, it was decaled with an EDTA decalcification agent and not a strong acid, which would really render molecular testing void. And then finally, we can assess the true tumor proportion and the purity of that tumor for that specimen selection. On the other hand, and in full disclosure, here at our institution, we rely on an oncologist-initiated testing paradigm for a number of reasons, but for the benefits here, number one, nobody knows better than the treating oncologist if testing is needed. They know if testing has been previously done at a different institution. They know if this is the primary diagnosis or disease recurrence. And they know for sure, probably better than the pathologist, if limited LIS access to the medical record or history is given, what the tumor stage is. And if this truly is an early stage disease that might go to surgery for curative intent, well, then maybe we don't need to be doing the testing on those small biopsy specimens. The oncologist really knows what testing is needed. Do we need more comprehensive genomic profiling for this particular specimen? Or is this disease recurrence where a more focused panel might be needed? Do we need a rapid EGFR in a patient? Who has a known EGFR mutation, and we're looking for a T790M or a C797S type of mutation to explain the resistance. Oncologists also know something about potentially the submission in if there's any liquid biopsy results that oftentimes bypass pathology. And this is something that we really don't know about. And so if a liquid biopsy has a positive result, do we really need to test on the tissue? And finally, the clinician knows the clinical urgency and knows when that testing is needed. Of course, the oncologist wants that information yesterday, and we can never get them that information soon enough. But there are some situations, such as, you know, the 14-day rule does still play a problem for Medicare patients who are inpatients at the time of their biopsy. And so sometimes we have to wait for that 14 days in order to get Medicare reimbursement for some of this testing. So really, I think that the take-home message that I'm trying to convey is that there really is no best situation, but you really need to decide what works best for your practice and for your hospital setting. One last slide that I'd like to share is thinking about what changes might be coming down the pipeline with respect to testing, because everything to date has really been focused on advanced stage non-small cell lung cancer. And with the FDA approval in December of 2020 of osimertinib as adjuvant therapy for earlier stage non-small cell lung cancers with EGFR mutations, largely derived from the ADAURA trial that was published in New England Journal of Medicine in October 2020, showing that patients with earlier stage disease that have EGFR mutations treated with osimertinib, a third generation EGFR TKI, in the adjuvant setting had significantly better disease-free survival compared to placebo. And granted, you can question the use of this endpoint of disease-free survival as opposed to overall survival, but now there is an FDA approval for osimertinib in the adjuvant setting. And so we might need to now initiate more regularly EGFR testing in the resection specimen setting. But you can anticipate, will similar data come out for ALK, ROS1, BRAF, et cetera? So it brings into question whether or not we might need to expand what we do consider testing in the reflex setting, even in the resection specimen paradigm as well. So my last slide in summary, I think that it is not an argument at all that in the setting of non-small cell lung cancer, ancillary testing is absolutely essential to direct the care by the oncologist of these patients. And at a minimum, we do need to test for all predictive biomarkers that have FDA-approved therapies in non-small cell lung cancer. And really, that's taking the shape of needing to have larger NGS panels plus PD-L1 immunohistochemistry. For the ordering itself, there's the option of the pathologist reflex testing versus the oncologist-initiated testing. And I really think you have to go with what works in your practice setting. And finally, it truly does take a team, and communication is the key between all stakeholders in order to maximize the efficiency of this process, in order to minimize the testing turnaround time and to maximize the testing success for all of these lung cancer patients that we see. So thank you for your attention. Now I'm going to pass the mic on over to Nero in the next phase of this talk, seeing how we can actually optimize and what lessons can be learned in non-small cell lung cancer biomarker testing. Thanks.
Wonderful. Thank you so much for such an informative presentation, Dr. Vanderlaan. It's now my pleasure to introduce Dr. Nirupama Singh. Dr. Singh is an assistant professor of transfusion medicine and molecular diagnostics in the Department of Pathology at the University of Alabama, Birmingham. She'll be sharing some of the best practices and lessons that she's learned on optimizing test ordering in her institution. After her presentation, we'll open up for a discussion. So Dr. Singh, the floor is yours if you'd like to share your slides.
Sure, thank you. I'm Niru, I'm at UAB. So thank you very much, Dr. Vanderlaan. Very nice talk, and I'm kind of picking up a few slides, few things that you talked about, and to let everyone know how we do here at UAB. And of course, thank you, Ms. Bloomer and ASCP for giving us the opportunity to talk. I have no disclosures. I have this slide here to kind of give us the idea where we were and where we are now. So I would like to say, I can give my age here, like in my lifetime, we achieved a lot, where we didn't know anything about the lung cancer, like in the sense of, yes, it existed, but the different types, and now these are big list of genes. But obviously the work is, if we are done, then obviously there's no moving forward. So we need to keep finding something new, something better for each and every cancer and for other fields too. As we know, based on NCCN guidelines, there are multiple drugs available for EGFR mutations, ALK, RAS, and so on. But this is not it. As I said again, there are more coming up. There are trials going on for your MET amplifications and the HER2 mutations. Whereas the AMP believes that there are multiple emerging markers right now for molecular testing in lung cancer, and we'll see how it all turns out. For the NTRK and FGR, we are already moving forward a little bit more than based on are more like for the KIT and PDGFRA. Moving forward, what does the CAP and AMP suggest for molecular testing? They say it should be must, the EGFR and ALK-RAS should be tested as the first line. And if these genes are negative, we should go back to, we should test those multiple genes, expanded panel testing for BRAF, MET, RET, HER2, or KRAS as a single or in the expanded panel. It's not that far away that we were doing as suggested here by the AMP with the EGFR Sanger sequencing, followed by ALK and RAS, ISC or FISH. And then if those are negative, we'll be sending it to send out based on the oncologist recommendations. Based on NCCN guidelines, they recommend very similarly like the AMP with the EGFR, ALK, and RAS, but they want the PD-L1 and the BRAF to be tested as the first line moving forward, then adding the expanded panel. We are talking about this TMB and MSI in lung cancer, but still there's no guidance. And as far as my understanding, our oncologists are not moving forward towards the TMB and MSI. At our institution, we do perform the MMRs, but we do not have the TMB testing at this point. Very nicely, this slide was alluded by Dr. Wendelon, by the presentation. I've got this slide here to kind of see how we do it. So for us, to start with, when we started our NGS, the radiologists, the interventional radiologists, the surgeons, or the pathologists were doing all the testing, and of course, as Dr. Wendelon said, it has a lot of good things like picking the best specimen, decreasing the cost in the sense like we are doing in-house. If radiologist has ordered some testing, it still has to be passed by pathologists. So the turnaround time is one of the best advantage of doing that. But moving forward, our oncologists, we had meetings with our oncologists and they wanted to move in a different direction. They wanted it to be the oncologist directed testing. And I like these words by Dr. Wendelon, if, what, and when, because the oncologists, they are the treating physician and they know much better. So I would like to say we were doing really good by pathologist directed testing. The only thing was because we'll look for the patient's clinical data and the impact, or like if there's any pathology was done before, if patient is here for the first time or the second time. But then there are many patients who are referred to at UAB. They might have a diagnosis before, but the way it works is the patient comes to UAB, seen by the surgeon first, and after the diagnosis, only it goes to the oncologist. So oncologist has not put any reports or any of their history. So we don't know much about what's going on regarding the patient's diagnosis. And some might be, as I said, like could be metastatic tumors, later stage, or some tumors where the basic NGS testing for EGFR, ALK, and RAS is done, but now they're asking for this new biopsy because they want the CGP testing done as the previous sample is exhausted, or something more that we don't know yet. So that's why oncologists wanted to take the testing in their hand, and they will be ordering that. And we'll see how it goes. The only disadvantage that I see is the delay in testing, and that can delay in the treatment because we still are using the haloplex-based technology. So testing itself takes 4 to 5 days, I would like to add, because the block, you have to pick the block, it's coming to the lab and starting the process, that's like minimum 5 to 7 days. So it's definitely delays in the process of like a testing and treatment, but obviously they are the best one to know which test they want. So that was our workflow was on the left before. It's since 2 months, it's on the right side, and we'll know in near future what is the best and what's working and what's not working. So our workflow it's now will be the oncologist-based testing, but the way it was like the sample we receive, we'll be ordering next-gen sequencing where we have a lung cancer panel that will include the BRAF, EGFR, and KRAS. If there's no mutation in the EGFR, we'll be ordering ALK and ROS IHC. And after that, we do not, and then obviously we do send out the PDL1 for 22C3 TPS. We do not do the fusion targeted analysis till the oncologist asked for it, but we do have in-house fusion panel where we use the Archer's multiplex technology. So with that, so I would like to say we are at the point that we started with the Sanger sequencing at our in-house. Now we do have NGS and the fusion panels. Our timeline was, our turnaround time was really going very well with us ordering the test. We'll see how when oncologists order, how it moves forward. And also, I believe there were a group of oncologists at our place who would like to have like a bigger panel, like they want all genes tested, 100 genes panel, 100 fusion panels, and that's what they would like to, they were sending most of these to other places to have that. And I'm not sure if our oncologists who are trained in lung, like which way they are trying to take control in their hand more, because sometimes we are doing the next gen sequencing when they do not want it and we are losing the sample, or it's more they're also moving towards one of those oncologists where they want a 500 gene panel, and we don't have that in-house currently. We do have a 50 gene panel solid tumor that we can run for some of these. If they want for squamous cell carcinoma, if they still want the next gen sequencing, we can do that. But yeah, that's the story, and I think we'll see how it all goes with that.
Great. Well, wonderful. Thank you so much for sharing your experiences, Dr. Singh. And as I mentioned earlier at the start of this presentation, I would now like to open it up for audience questions and discussions. We want this to be interactive. We really want to hear from you. So if you would like to speak, if you don't mind using the raise hand functionality in Zoom, then we will call on you and you can unmute yourself. And if you're not quite sure how to do that, if you look usually in the bottom of your screen under the reactions tab, kind of in the lower right corner of the screen, if you click on reactions, there should be a button that says raise hand. And if you click that, that will let us know that that you're interested in speaking. So one of the great things about the Project Echo sessions is that it really gives us a chance to come together to talk and share our experiences and learn from each other. And our goal is to create a safe space for these conversations to happen. So if you have anything that you'd like to share, even if it's just sharing how you're currently doing things at your institution, if there are any challenges that you're encountering, I don't think we'd be having these discussions if test ordering for advanced NSCLC was cut and dry. There's so many nuances here, so many problems that people experience. So if there's anything that any of you in the audience would like to share, we would really love to hear from you.
Well, maybe to get things kicked off, let me ask a question. So, Dr. Singh, thank you for sharing, your experience at your institution. how about the liquid biopsy? Liquid biopsy, I'm curious to hear, because, it sounds like your oncologists are pushing for the bigger panel, more data, more, which is what our oncologists want as well. And it basically, our oncologists here do both a large, tissue testing next-gen sequencing panel, but they also do a liquid biopsy on every patient in clinic. And there is literature to show, that if you do both, you catch more. But it can be a challenge, right? It can be a challenge, cost and also the kind of politics of maybe bypassing the pathology department with this testing. So very curious to hear your experience or thoughts on that topic.
Yeah, so for us, they do send the liquid biopsy. It has to be a send out. My understanding is so far they were using it for metastatic tumor, most probably I would like to say for the T790 resistance to check, but not as much as often, I would like to say. At this point, they're looking for just the bigger panels for, and also we are in the process of moving forwards to get, we are using Illumina technology. We are moving forward to ion torrent and getting bigger gene panels to kind of, because I feel like that's where the field is. I know a few places that our oncologists are talking. They do this comprehensive genomic panel along with the transcriptome. It's very easy done. They're very efficient, and I think that's what they want. We were saying so far that we don't need to know all this stuff. I don't know, but I think we have crossed that line. We were a little behind, so we need to catch up and move. If that's what they want, that's what they want. We have to move forward with that way. And of course, it's easy said than done. If there's someone in my family who has this cancer, I would like to know everything. So it's that like I don't know what is the best and the better and how to approach. But yes, liquid biopsy only for metastatic cancers when they do not want to do the biopsy. As far as my understanding, they're not sending for all patients.
As a reminder, it would be wonderful if anybody has any thoughts that they would like to share on this presentation, just raise your hand throughout. We haven't had anybody volunteer yet, so why don't we go ahead and move to the next part of the presentation, and I'll introduce Kimberly Bennett and ask her to share her experiences. Ms. Bennett is a medical technologist at Bryan Health in Lincoln, Nebraska, and then following her presentation, we'll open back up for discussion. So Ms. Bennett, the floor is yours.
Thanks, Kelly, for your introduction. My name is Kim Bennett. I'm a medical technologist in Lincoln, Nebraska. I don't have any slides to share. I want to talk with you guys about an experience I had regarding I worked for a group of general practitioners, and about 3 years ago, we started a new physician office laboratory in a new clinic and how all that went down. And so I wanted to share the experience about that and about how my vision was widened about how important it is to have a really good relationship with IT professionals. I can say that. So about 3 years ago, 2 other medical technologists and myself were involved with the startup of a new physician office laboratory. This lab was to serve a newly built clinic for general practitioners. So again, this is not specific to lung cancer, but I just wanted to share a lab perspective. The entire staff of all the clinic, the lab, the radiology had abandoned this endeavor. With the startup of the lab, the instrumentation alone is so extremely complicated in and of itself that I'm only going to address test ordering itself in the electronic health records. Before our clinic opened, all of us had to go to training to learn the new electronic health record, as all of us had previously worked with another system. And when our clinic opened its doors, our company provided us a team of IT specialists for about 3 to 5 weeks who came in, basically stood by our side, helped us to learn Epic on the job training, and helped us walk through what we should be doing properly. And they also helped us pinpoint problem issues that they helped us smooth through or helped us figure out how we could work on it or what they could do for us to help with that on the IT end. Our entire team was affected by this change. Not only to start up a new clinic, but learning a new electronic health record is daunting. This affected providers, nurses, radiology technicians, lab technicians, schedulers, billing, anyone else involved. Barriers and challenges. This was quite a whale of a challenge. Our test compendium was not built very well. So when we opened up our clinic, it was quite a challenge from the provider's point of view. They were only given a small bit of choice to what to order, whereas they were used to having such a large choice. So providers and nurses had several options for the same test, and it was really confusing. Also, because our lab was not up and running, we had to send the lab work to a third-party laboratory outside our company. There was also an oversight in the lab test compendium, billing, and coding, which caused the phlebotomy fees not to be charged or collected by our clinic for about 6 months. We lost about $100,000 of revenue just from that mistake alone. During the first 6 months, we sent out a large majority of our testing. And during this time, the 3 technologists were being trained on all of our instruments. It does take a while to learn a new instrument, but what we were, not only just that, we were trying to get the test compendium down. We had to ensure that all instruments, reagents, QC calibrators, linearity were all performing as expected. But in the electronic health record, under the lab testing and ordering, we had to make sure that all the lab CPT codes were correct for each test ordered. And as you know, CPT codes are unique for each test. The CBC, for example, would have a different CPT code than just a hemoglobin test. CPT codes are unique to a particular test, so that billing and insurance is the same across all institutions. It's important for reimbursement from insurance, Medicare, and Medicaid. When building a lab test compendium, it is imperative that when lab tests are resulted into the electronic health record, that each test has the correct reporting units built into the electronic health record. These are all things that I took for granted before we opened up this new clinic, new lab, because all these things were not already built in. The techs, along with IT, we all had to do this ourselves, so it was quite daunting. Also, each test, when being resulted into the electronic health record, needed to have a corresponding reference range based on the age, sex of the patient, of course. And in some cases, some tests that also need to have to factor in the weight of the patient and other factors. Before we could get to the stage where we could result out in-house laboratory to the providers, all of these parameters needed to be tested before to make sure that all the results the doctors, providers saw were accurate. We had another challenge as well. The team that originally built the lab test compendium for the providers did not word the test very specifically. Sometimes a provider or nurse would actually accidentally order the wrong test, and lab professionals contacted the provider or nurse to verify which test the provider wanted. So again, that was eye-opening for me because I'd never had this, never had come across this before. Being very specific is very key. So for the first 6 months to a year or so, we were cleaning up and clearing up confusion on many levels to help make everyone's jobs easier, specifically the providers. In the first year or so, many common tests such as magnesium, ionized calcium, and ANA were not easily orderable. The provider had to put a note in the electronic health record. That's called unsolicited tests. And on the lab side, this meant that we had to fill out a handwritten requisition for the lab tests ordered and obtain a demographic and insurance sheet from somebody who had clearance to give us that information. We weren't allowed to do that. We had to manually barcode the tests and manually write patient's name, and all of that hoo-ha took about 15 minutes, maybe longer, which was frustrating because this was time could have been spent elsewhere. Sometimes when we were still building our compendium, say the provider just wanted an ANA, and we had kind of a indication that maybe the provider wanted a specific type of ANA or maybe a panel. A lot of times we had to go to the provider or the nurse and ask them, which panel or which ANA did they prefer. So successes, I wanted to tell you for sure that after about a year of craziness, everybody in the clinic, the providers, the nurses, the lab, the schedulers, the receptionists, the billing, everybody was very ecstatic when our whole process became as flawless and flowed as well as it could. As you know, in the lab, there aren't very many gray areas, and it's, pretty much black and white. To state the obvious, the patient's life depends on the quality of work we do and helping our providers. And again, as Dr. Van der Laan said, effective communication is definitely key. And that's all I have to share.
Wonderful, wonderful. Well, thank you so much, Kimberly. It sounds like you've had quite the experience on your testing journey. We really appreciate you taking the time to share your experiences with us all. So we are now going to open back up for audience discussions and questions. So please feel free to raise your hand. Again, you can use that finding the reactions button in your Zoom. And then clicking raise your hand. And it looks like Chris Fox has raised their hand. So Chris, if you'd like to share, unmute yourself and introduce yourself, then share your experiences. The floor is yours.
Hi, yeah, I'm Chris Fox. I'm a pathologist in Wichita, Kansas. I don't really have a specific question, I guess. I just was going to share kind of our experiences in relation to the biomarker testing. And because this has just come up, it's very timely. We have for years we have been doing this as an oncologist-driven ordering process for the biomarkers. For many of the reasons that were covered here. However, now we have oncologists requesting this to be a pathologist-driven process, and which I can understand the request for that. However, there are certain situations in which we just can't do that. Patients will come in with an outside diagnosis. We have no idea that has happened, or sometimes the patients are not even going to be treated, and so they don't really require any, if they're palliative care, they may not need testing, and so then that would create a lot of over testing, and so it seems like there's frustration on both sides, and maybe there's no clear answer. I was hoping maybe I would get an answer today as to what I should do. And then I guess, the other thing I was going to, maybe this is a question. We send out most of our biomarker testing as a next generation sequencing panel to an outside laboratory. And so we get a result, we get a 12-page result back from them with, texts, pages worth of text of descriptions and disclaimers and things. And it's difficult for us we can't just attach that to the report. And so I've had some difficulty trying to summarize the important information and get everything in there that they need, and to add that to our report as a synoptic report. And so I just was wondering if maybe if you have some suggestions or guidance as to how to go about doing that without creating a 15-page report.
Yeah, I can jump on here, Chris. Number one, I feel your pain. You know, in the real world, or in an ideal world, reflex testing is great. And the oncologists want all the information, right when they see the patient. But then on the flip side, they get angry if testing was done and you didn't need it, and the patient gets billed, right? If you did testing and it's the wrong testing, or if you did testing and they were actually wanting to use that biopsy for a clinical trial or for another use, and so it's kind of a catch-22 there. And so, so first off, I relate. I feel your pain, and this balance between reflex testing and oncologist-initiated testing. It's complicated, and you have to find the lesser of two evils in some instances. Your second point about so sending out and then getting the reports back. That's that post-analytic phase that, again, nobody really talks about or thinks about, but it's actually a big issue. And if I were to rewind here in our practice, probably about 7 years ago, in our lab information system, we really didn't have the ability to upload PDFs of these beautiful, comprehensive 35-page reports like we do now. So, kind of spoiler alert, we've been able to work with our lab information system to actually upload the PDFs, the actual PDFs and not scans of these really complicated reports. But in the past, yeah, we were basically getting these results in EGFR, ELK, ROS1, and adding them as a text addendum to the original path report. And exactly as you were saying, trying to identify what was the salient information, what do we include, what do we not include? Do we have to include the whole gene list that was tested? Do we have to include, variants of undetermined significance? And then referring to this, mystical, complete path report that somewhere, maybe it's in the medical record, maybe it's at the testing facility. So yeah, so that was a major problem. And the impetus to move towards an LIS solution of being able to upload the actual PDFs. And so there's no ambiguity in, the message that the pathologist was conveying. And so everything was there. But once again, you need buy-in from your LIS and your, the people that actually control the scenes of the medical record to, facilitate what you can and can't do. So great point. And, once again, I feel your pain. We've been there.
Yeah, absolutely. It's if I have to do that job, it's kind of really hard. Because these panels are really big. I don't think I know enough to say what is important and what is not. Like those drugs available for which gene, and it's kind of complicated, but I think that's what it's for us. It's saved somewhere and the physician can see that report. The other thing when we were talking about the panels, so as I said, we have separate panels, and then it's not for the lung, but for our heme, FISH goes to another department. So we are having these 4 or 5 different reports. And our physicians were also, most like hematologists, were upset about having these 10 different clicks they need to see instead of having a comprehensive report. And then they're sending us these outside places that they have a very nice comprehensive report, and it does kind of looks really good. So I hope slowly we all can be there and we all can do our own comprehensive testing that's good for the patient and good for us as a pathologist and oncologist. As I said, in 50 years, we did reach a lot. We know a lot. But now the problem is we know really a lot. The whole point is how to put that information in the right way in the system so it can be used by the patient. So that's where we are. A lot of information, just not sure how to convey it and how to convey the best information.
Great. Well, I think this has been such a wonderful discussion, and I'm so sorry to have to cut things off, but we are at the end of today's ECHO session, and we definitely do want to thank you all for all of the sharing, and looking forward to future ECHO sessions with all of you. So I'm just pulling up a quick slide here. So I just wanted to let everybody know we appreciate all of your participation. Our next Project Echo video conference is on Thursday, June 24th at 2 p.m. Eastern on best practices in advanced NSCLC specimen management. And we'll also be looking for additional volunteers to share their challenges and lessons learned on this topic. So if you're interested in participating, please either let us know in the chat or drop us an email at grants@ascp.org. And if you want to claim CME or CMLE credit for participating in today's session, please visit the lung cancer page on ASCP's website or go directly to the ASCP store using the link that's been placed in the chat. ASCP will also send directions and the links for claiming credit to the email address that you registered under. And then finally, we would also sincerely appreciate it if you could please take 30 seconds to complete the brief survey at the link that's just been posted to the chat. This helps us with our outcomes evaluation and helps shape future educational sessions. And we sincerely appreciate you taking the time. It's a really brief survey. It's 30 seconds, a minute max, just to help guide future educational projects. So thank you again. This concludes today's presentation.